Okay, thank you. Welcome everyone to tonight's webinar, Cataracts and Presentations to the Eye Clinic and Diagnosis of Colorectal Cancer with Local Ophthalmology, Gastroenterology Statewide Referral Criteria Implementation. My name's Ali Sullivan. I'm an Education Coordinator for the Western New South Wales Primary Health Network, and thank you all for attending tonight. I'd like to begin by acknowledging the traditional custodians of country throughout Western New South Wales and their connection to land, water and community. I pay respect to elders past, present and future and extend that respect and a warm welcome to all Aboriginal and Torres Strait Islander Australians present tonight. Just a little bit of housekeeping. Any questions, if we could put those into the Q&A tab, and then we'll look at the questions after the presentation of each speaker. At the end of the presentation tonight, we've also got a short evaluation and our annual primary care education surveys open. So we've just put a link up for that as well. If you've got a few minutes and you'd like to fill that in, that would be wonderful. So tonight we have two guest speakers, Dr. Jeremy Curtin and Dr. Ted Staglosa, and I'd like to thank them both for presenting tonight. Just a brief bio on each. Dr. Jeremy Curtin will be our first speaker. He's a regional New South Wales-based ophthalmologist. He's a fellow of the Royal Australian and New Zealand College of Ophthalmology. His special interests include general ophthalmology, cataract surgery, retinal conditions. He practices in Orange, Forbes and Dubbo in both the public and private clinic. He completed his intern and residence years in Orange and spent a further 6 years in an accredited ophthalmology training position in Melbourne. Further to that, he did a year in the UK before landing permanently in Orange, and he's one of 3 ophthalmologists that service the Dubbo Public Eye Clinic. Ted Staglosa is a consultant, gastroenterologist and hepatologist on-call physician for general medicine working at Dubbo Base Hospital, Mudgee Health Service and the Dubbo Private Hospital. He's an honorary clinical lecturer for School of Rural Health in Dubbo for the University of Sydney. Dr. Staglosa also contributes to the Gastroenterology statewide referral criteria and accepts all referrals and all conditions listed in the GSR. Jess Ray is also on our panel tonight. Jess is a Senior Project Officer at the RDN and she'll assist with the Q&A. Erica Gilbert, my colleague, and Zach Miles are here for support. So thank you all for tonight. Jeremy, I'll hand over to you now. If you're ready, you can just share your screen and your slides will start, or I can present from this end.
Yep, hang on one second.
Yep, sure.
Actually, I'll get you to do that, Ali. Actually, that might be
that's
safer.
Fine. Okay, so
We'll go to the next
you just
slide.
tell me when to go, Jeremy, and I'll just mute myself now. Thank you.
Thanks, Ali. Good evening, everyone. Thanks for letting me have the opportunity to speak tonight, and it's a really great honour to be able to reach out to some of our referrers and to some of the partners that we work with in the public eye clinic in Dubbo. And I guess the reason for the talk tonight is to be able to introduce everybody to the statewide referral criteria for ophthalmology. But that is a relatively recent development and still is going to need to continue to be an evolving piece of work. But it's great if we can start to get to meet our referrers, because referral criteria are really a two-way interaction between the resources that we have in our clinic in Dubbo and the demand for clinic spaces. Just to give you a little bit of history, I suppose, the clinic is now located on level 1 at the new outpatients area in the hospital. we've got a really great setup there with excellent equipment, and it's a big step up from our previous home across the road. So we've been there for about probably 2 years now. The consultants in the clinic are myself and Chris Qureshi. We've both got a very strong interest in rural and Indigenous health, and this year we've been able to take on a fellow as well, Josh Lane, who's a local boy from Coonamble, who's in his final year of ophthalmology training and has decided to spend that year working with us in the clinic in Dubbo, as well as with me in Orange. So we've got clinic running about 2.5 to 3 days per month, and it's a fairly general clinic where the main services are cataract assessment and surgery, which probably constitutes about 50% of the work in the clinic, retinal diseases, which are becoming more and more the treatment of retinal disease with intravitreal injections for macular swelling from either macular degeneration or from diabetic eye disease or retinal vein occlusions. We treat pterygia. We also treat oculoplastic conditions such as skin cancer around the eyes, situations like eyelid malpositions for ectropion and photosis, where the patient's eyelids are inadequately protecting the eye or potentially obscuring the patient's vision. We have a glaucoma service, and we see patients with neuro-ophthalmic conditions, things like optic neuritis, potentially temporal arteritis, cranial nerve palsies, would constitute probably 90% of our work in the clinic. Other services that are a bit less readily available are vitreoretinal surgery, subject to funding. We have Josh helping with pediatric ophthalmology up to a point. We don't have an orthoptic service specifically for screening children's vision, but we do try to help out as much as we can with pediatric referrals in the area, and wherever we can, we try to help the emergency department at the hospital. Obviously, three days a month is not an all-day availability or an every week availability, but if we can follow up patients from emergency, we do our best to do that as well. We can go to the next slide. Ali, thanks. So many people would be familiar with our standard referral form. This is the DPEC clinic referral that's been running for some time now. It's available from the clinic manager, which is Shay at the moment, or formerly Tori, who's now on maternity leave. And many of the things that come up in the statewide referral criteria are on our existing referral slip, but I suppose the statewide referral criteria is really trying to standardize as much as possible the point of entry into public hospital clinics, and so you'll see a lot of the same things coming up over and over again. And perhaps one of the important messages of the talk tonight is that there are a few simple things that ophthalmologists really like to see when we try to triage patients into the clinic, and we don't expect everybody to be able to do those things because it's sometimes very technical, but I think everybody can liaise with some of our local allied health providers, like our optometry services in the area, to try to give us a better quality of referral to allow us to safely triage patients and appropriately utilise our limited clinic spots. We'll go on, Ali. So again, there's a lot of conditions that we see, and I think one of the themes in public clinics is that because it's there are so many conditions out there, it's very difficult for referrers to adequately or to accurately know exactly what they're sending into us. There's probably 80 different diagnoses on this referral criteria here, and so many of these also come up in the statewide referral criteria. But I suppose the message here is that for somebody who doesn't have all the equipment necessary to make these diagnoses, or even to sort of try to filter through them, you do need help to qualify your referrals, and that's again where liaison with local optometric services is very helpful for us, to encourage our non-optometrist referrers to improve the quality of their referrals. Let's go on again, Ali. So the statewide referral criteria were developed, have been developed over the last few years, but were released this year in July for ophthalmology and gastroenterology. And it's basically a decision support tool communicating the minimum clinical criteria and referral information required for referrals to New South Wales public specialist outpatient services. They're designed to support referrers when making referrals, as well as New South Wales outpatient services at the point of screening and triage. They're seeking to improve the quality of referrals, minimise the clinical variation in referral practices and triaging, and reduce unnecessary waiting on outpatient wait lists. So it's really aiming to enable safe, timely and effective triage of patients to services. Thanks, Ali. And the initial release of ophthalmic statewide referral criteria deals with about 10 conditions listed here. So age-related macular degeneration, adult cataracts, which I'll be talking about tonight, diabetic retinopathy, glaucoma would probably constitute about 75% of our work in the clinic. And then there are some other important but less common areas. Many of these are pediatric, so pediatric cataracts, children with absent red reflexes, children with turned eyes, children whose eyelid height is abnormal and potentially obscuring the visual axis, children with apparently reduced vision, unequal pupils, and swollen optic nerves. So again, not things that everybody can diagnose, but certainly things that people can be aware of and send the patients in the right direction to help make that initial detection of a problem. Thanks, Ali. And again, it's really important to remember the context that we all operate in out here, which is that we have an isolated patient cohort. I've just done an audit of my own cataract surgery patients in Orange, which is, the distances are a little bit smaller, but over 30% of or approximately 30% of my patients having cataract surgery travelled over 100 kilometres for their surgery. So these are patients with limited access to primary care, to GPs and optometrists. They're serviced by predominantly visiting specialists. So even the more local specialists in our clinic don't live in Dubbo necessarily, meaning that the patients have limited access to care. Because of that, the patients have a higher acuity, I suppose, of problems, of often multiple problems running into each other, which can confuse the diagnoses. And even to us, the biggest issue sometimes is trying to untangle all of the various issues and work out which one is causing the biggest impact on a patient's vision. We've also always got to have a high suspicion for hidden issues. It's often not just a cataract, but it could be a cataract with an underlying retinal problem or a background history that's more complicated than initially than it initially seems. And I think all of these things require a greater interaction with our optometric colleagues. And I think the number one take-home message for anyone listening tonight who doesn't have a lot of experience with ophthalmology is that I think we're so lucky to have so many capable optometrists in Dubbo and in the area who can really help to sift through patient problems when they're not acute and when they're not surgical. And I do think it would be helpful for all of our patients to be in regular contact with an optometrist as they start to age and for somebody with no apparent problems, I think 1 to 2 yearly reviews with the optometrist for older patients or anyone with a positive family history of eye problems would be a sensible point to start to build up some information for GPs on their files, so that when things do potentially start to change, we know what the patient's baseline was. Thanks, Ali. So the statewide referral criteria cover five areas. The first, and these are the same across all the presentations. First one is what is an emergency presentation that doesn't belong in the outpatient clinic and instead belongs in the hospital or at a higher level of care. Number two is what is out of scope or what care is not routinely provided. So conversely, what is not suitable for an outpatient appointment, what's not yet ready to take up that clinic space. And then number three is what is suitable and what level of priority or what category does that presentation require, and how soon can a referrer expect a patient to be seen for a particular problem. Number four lays out the requirements for referral. So what are the actual items that we need to be able to properly triage patients who need an appointment? And then number five is what other content helps us to complete the picture of the patient in question, and what helps to make their experience a safe one and a culturally appropriate one. Thanks again. Just a quick refresher for anyone who's a bit rusty. When we look at the external eye, there are a few important landmarks. I suppose we're working from outside in, and we've got the upper and lower eyelids, which are effectively the protection for the eye. So the eyelid position is important. The appropriateness or the ability of the patient to blink properly and to roll their eye up when they're blinking, which is another protective mechanism. We've got the white conjunctiva overlying the sclera in a normal uninflamed eye, and then we've got the limbus, which is the circumferential limit of the clear cornea, the visual part of the eye, and behind that the brown iris and the pupil on show in this picture. In the sort of on the left hand side of this picture, you've got the lacrimal system visualized, and in the very corners of the eyelids are the two drainage holes which drain into the pink canaliculi, which are lower and upper systems visualized here in the nasolacrimal system, which drains tears into the patient's nose. Thanks again. And then a diagrammatic picture of the eye, of the schematic eye, which I guess shows the horizontal section of the eye. And on the left hand side in yellow, we've got the cornea, which provides about 60% of the focusing power of the eye. So that clear window bends the light, which then passes through the pupil hole and in through the lens, which we're about to talk about. The lens is in yellow there. It's suspended in the front 1/3 of the eye. It's hanging off the ciliary muscles, which can contract to change the shape of the lens and increase the focusing power of the eye for near vision. We've got the vitreous cavity, which houses the retina, which is sort of shown in pink here, the retinal blood vessels, and then at the back of the eye, the optic nerve. And there's a very small depression above the optic nerve for the fovea, which is our most sensitive photoreceptors that essentially do our fine vision and our central vision. Thanks again. Just to quickly refresh everybody, when we're testing a patient's vision, we really it's important to know what a patient can see in normal life, but to actually interrogate that properly, we need to test one eye at a time, because a patient with one blind eye and one good eye can be almost completely normal in day-to-day life, and even some patients don't realize that one eye can be a lot worse than the other if there's one eye that's normal. So we've got to test each eye separately, and we want to know what a patient's uncorrected vision is like, but even probably more useful is knowing what the patient's visual potential is. So what can the vision be corrected to in their glasses, or if you don't have their glasses, a little pinhole, and there's a patient on the right hand side there with an occluder with little pinholes in it, and pinholing a patient's eyes is essentially like giving them a properly fitted pair of glasses. It minimizes the scatter of the rays onto the back of the eye, and demonstrates often an improvement in vision that gives the ophthalmologist or the optometrist or GP a much better understanding of how good a patient's vision can be. So in the image that's shown, the Snellen chart, this is our sort of standard clinic measure of a patient's vision. That's a chart that's normally tested at 6 meters, and by convention, the testing distance is stated first. So it's like a fraction, I suppose, a proper fraction with the testing distance 6 meters over the number or the distance, I suppose, that the patient can read, or the line that the patient can read. So if the patient can only see the top line, that's normally referred to as 6 over 60, and 6 over 60 is the level of legal blindness, actually. So if a patient can only read that top line, by definition, they would qualify for to be legally blind. So a normal patient would be expected to see that H at 60 meters, whereas a patient who's reading that at 6 meters has very poor vision. And then if you go down to the second big red arrow there, around the 618 over or 612 mark, so a patient that can read that OLHA line there, the 18 meter line, is on the borderline for driving. So what somebody can normally see at 18 meters, this patient would see at 6 meters, meaning that they need to be a lot closer to that letter to see it, to see what a normal patient can see. So around that level, 618, 612 is driving. Their driving's at risk, and at the top of the chart, you know, they've got very poor vision. Thanks, Ali. So with regards to the topic of cataracts that Jess wanted me to cover, you remember the picture of the yellow lens that's suspended inside the patient's eye. So I mentioned that the cornea bends or refracts, does about 60% of the refraction in the eye. Well, the human lens does about 30%, and then the other 10% is made up of the tear film, which also has a refractive property. So the lens helps to bend the light clearly onto the back of the eye. The lens inside our eye, it is flexible in our younger years to allow us to change our focus for near targets, and that's called accommodation, which deteriorates as we get older, requiring many people to start to wear reading glasses. And that lens gets opacified or a bit cloudy as we get older. It's a part of normal aging, but it's sped up a little bit with disease and trauma. The common symptoms are loss of focus and clarity, difficulty reading signs at a distance, and often glare. And it obviously increases the potential for falls for patients. It reduces their quality of life. It creates problems with driving and can even lead to blindness. But in the normal situation, it's a painless problem in a white, uninflamed eye, and can be quite asymptomatic often until it's very advanced. So there are patients that sort of wake up one day and noticing that they can't see very well anymore. And in fact, it's probably been happening for a very long time, and they've been compensating or just managing it. Thanks again, Ali. So this is just a picture of a pretty normal lens or an early cataract on the left-hand side, and then on the right-hand side, a white cataract that would be 660 or worse. So that would be a sort of a blind person's cataract on the right. Next slide. And here we've got another patient who's got a normal looking left eye. So that's on the right hand side of the screen. So that dilated pupil that's black there is probably a clear lens or a lens without a cataract. And on the left, which is the patient's right eye, he has a white cataract in that eye. So it's good. It can be quite asymmetric in this situation, but if you see it like that, you've got to look for other reasons like inflammation or perhaps previous trauma or a history of treatment with steroid eye drops, because steroid eye drops can increase cataracts, and just steroid treatment in general. Thanks again. So talking about cataracts in context of the statewide referral criteria, what is an emergency on the cataract criteria, or what is an emergency in general? They're clinical presentations or red flags where health professionals should send the patient to emergency or seek higher care, phone the on-call medical practitioner, for example, and they want us to look at those when we're referring to the public specialist services. Thanks again. So in the context of cataract, there's only two emergent situations, and one is the very important situation of a patient with a history of recent cataract surgery. So I would say within the first week, a patient with increasing pain, with increasing redness or significant blurring of their vision, flashes and floaters, would be an important patient to seek the right help for. I would sort of say the most important thing to do in that situation is to contact the person that did the operation. I've definitely had patients who've gone to emergency and have been sort of seen and dispensed or moved on from the emergency, and the surgeon hasn't really been notified. And I think that it's probably more helpful in that situation to just contact the surgeon directly, or have the patient do that, because we're always available for the patients we've operated on, and I even give my patients my phone number, because I'd much rather know about something that wasn't a problem than find out later that a problem had occurred and I hadn't been notified. So that would be my recommendation for anyone who's within the first week of a cataract operation, is to just liaise directly with the surgeon. And then any patient who has a suspicion of acute angle closure should be directed to an ophthalmologist or to the emergency department, or at least to an optometrist. So acute angle closure is basically intermittent obstruction of the drainage angle in the eye, which is a painful blurring of the patient's vision. It's often accompanied with halos, and tends to happen at nighttime or in low light when the pupil is dilating and kind of blocking a very compromised drainage angle in the patient's eye, and that blockage tends to make the pressure go high in the patient's eye. And when the pressure goes high acutely, it causes a lot of discomfort, and then patients might find that it sort of intermittently relieves itself, but over a few nights becomes a repetitive thing, and that's often the sort of clue, is that it's been happening subacutely for a little while, and then all of a sudden becomes a permanent discomfort and blurring. So yeah, with those situations, you need to call an ophthalmologist or direct the patient somewhere that they can be appropriately diagnosed and directed. Thanks, Ali. Yep. So this is that example of the problematic patient post cataract operation. So within the first week of cataract surgery, anyone that comes up and looks like this obviously needs to get directed back to their surgeon, and that eye is not normal. That is not the normal red that you see after a cataract operation. So the eye can be red due to the anesthetic block, but the cornea there is obviously cloudy, and there's also infection in the eye. You can see at the bottom of the cornea there, there's a white collection of pus there, and that's called a hypopion, and that's really one of the telltale signs of a post-operative endophthalmitis. So that's what that looks like. Next photo is this is acute angle closure. So you can see a mid-dilated pupil. You can see the eyes pretty badly injected. It's red. You couldn't tell me that was an uninflamed eye, and even to the untrained eye, I think that the cornea is cloudy there, and that's edema developing due to the pressure in that eye. And so you see this pupil trying to dilate, and what's happening internally is that the drainage angle is being obstructed. So it's usually an older patient, somebody who's got a short or a small eye, and they're often developing cataract as well. So all those factors compromise the drainage of the aqueous in the eye. Thanks again, Ali. Yep, this obviously is not normal, and but it can be hard to sometimes to remember what's normal when you're a bit out of practice. But again, a very grossly injected eye, and that is an opaque cornea, so there's no clarity in the cornea, and this is a patient with a chemical injury. But again, sometimes it's helpful to know what's very abnormal so that we can have an image in our mind to work off. Thanks again. And this is just a picture of a penetrating eye injury. So you can see the ovoid pupil, it's not round anymore. There's something on the right, or it's the left side of the patient's eye, but it's on our right side of our screen, and there's some brown tissue popping out of the cornea there after a penetrating eye injury. So again, these are sort of gross signs that can be missed easily, but even the shape of the pupil there is a bit of a clue that something's not right. Thanks again, Ali. I'll just try and skip along a bit here so I don't run out of time. So talking at the other aspect apart from emergencies is what care is not routinely provided by the clinic, and this is important so that we're not wasting clinic spaces on patients that aren't yet ready for care. If we go to the next screen, so these are things that we really need the help of our colleagues to determine. So cataracts that don't cause sufficient visual symptoms or limit the patient's daily activities. Patients that haven't actually had a proper optometric screening or previously seen an ophthalmologist. But I guess for out here, that's probably not likely. It's more that they haven't been worked up by an optometrist to see whether glasses might fix the patient's vision. If the patient doesn't want surgery, they're probably not a good candidate for a cataract referral potentially. Again, looking at their ADLs and whether they're safely able to achieve them or not could be considered. And there's a thing called refractive lens exchange, which is basically cataract surgery or surgery to get people out of glasses, and that wouldn't really be a good use of our time in the public clinic. So we need our optometrist friends to help with that. Thanks again, Ali. So this is just talking about what constitutes access to the clinic. So these are the patients that do need to come, and how should they be given when do we fit them in? Let's go to the next slide, because they're just category 1, 2, and 3 there. So category 1 referrals within 30 days are basically the patients that are kind of legally blind, 660, like I said, and probably I reckon 5% of our patients have that poor level of vision for various reasons. So category 2 within 90 days is still pretty fast for a busy clinic, but if the vision's worse than 660 in one eye and they've got other sight-threatening problems that can't be managed properly because we can't see what's going on, or if the patient only has one eye. And I think my experience, probably 20% of our patients in the clinic have only one good eye. So a cataract in that eye is obviously much more debilitating. Perhaps, like I said, 10 to 20% of patients in that category at the moment. And we'll go to the next slide. Category 3 are sort of patients who are managing, but there's still a significant impact on their activities of daily living, and their glasses aren't managing. They're not managing with glasses anymore. They're interested in surgery. So they're category 3 patients who'd be seen within 12 months at the moment. and that's 70%. Thanks, Ali. Yep. Oh, yep. Sorry, that's good. So what are the referral requirements? Let's go to the next slide and we'll have a look. So best corrected vision, we need to know what that is by an eye professional, although a GP could certainly do that part, but this part, refraction, is going to be difficult unless you're an optometrist. So we want to know how strong the patient's glasses are, because it gives us clues about what they're going to need and how we're going to manage the patient, because some patients, perhaps they can't wait another 12 months for their other eye to be done if they've got a big difference between the eye that's had surgery and the eye that has not. So whether it's the first eye or the second eye that's had surgery, how long they've had symptoms for, what the impact of the cataracts are on their ADLs, and any other relevant eye pathology. Thanks, Ali. Yep. So this was just an example I made up. So a patient who's got 6/18 vision in the right eye, which is very borderline for driving, and 6/60 on the left, so they're already blind in their left eye, who's in +6 glasses, so they're in very strong glasses, which means that they're not going to tolerate having one eye no longer requiring glasses after a cataract operation, and one eye that still does. So they may need expedited surgery. So you have to consider whether it's appropriate for them to have their first eye done yet, because you know that their second eye will need to follow soon after. And this thing called anisometropia means that if the refraction in the patient's glasses changes at the time of cataract surgery, which it often does, they'll be very unbalanced. So we need to counsel the patients about what to expect at the time of surgery, looking for other potential issues with regards to the duration of the problem. So again, if this patient's been driving for a long time and their vision's very bad, it does give us a bit of a clue about their level of insight, or how isolated they might be. If they've been having falls or an accident, then it might be somebody who needs expedited surgery, and all the other eye issues can play into a cataract operation in terms of how successful it might be, and what the patient can expect from the operation. So a patient who's had a lot of childhood eye injuries may never return to good vision in that eye. So we need to counsel the patients, because a lot of people will say that their friends had an operation that was successful or unsuccessful, and that may or may not be the case, depending on the particular patient in question. Thanks, Ali. And any other information that's relevant. Let's go to the next slide again. So it's always great to have their general health, because we know about their other medications that they're taking, which can affect the surgery. Their allergies are important, whether they need an interpreter, whether they're capable of making decisions and consenting for their own surgery. If they're professional drivers, it may be critical that their operation takes place at a certain time, or before the vision gets too bad. Who's with them at home, who can look after them and help them, take them and bring them. Whether the patient's a falls risk, and obviously our clinic in Dubbo is very keen to look after our Aboriginal and Torres Strait Islander patients. So that's good to know whether they're disadvantaged or at risk. And some of these tools down the bottom may be useful to help quantify the patient's symptoms, but often, again, the optometrist would be the best person to help with that. Thanks again, Ali. So from my perspective, when I see a patient in the clinic for a cataract, I want to know how their vision's going, so that I can sort of put them into the sort of stratify them, I guess, in terms of how quickly they might need the operation. And the refraction, like I said, it's important because it gives us clues about the patient's eye and how the eye is going to be at the time of the operation, and also how quickly the patient needs this operation and their second one. Other ocular problems affect the prognosis for a cataract operation. So a bit like a camera, you can change the lens in a camera, but if the film's no good, the photos will still not be good. And so with the eye, if the retina's not healthy for any other reason, that might affect the success of a cataract operation. General medical problems can affect cataract surgery, like a tremor, whether the patient can lie flat, whether they've got a respiratory problem. It means that they cough, they need to cough a lot. Can affect our ability to get a safe surgery done. Allergies are important. And then the biometry, which is basically the measurements of the eye, We factor all the different measurements of the eye, the shape of the eye, the length of the eye, where the lens is going to sit in the eye, helps us to plan the operation and ideally to give the patient their best spectacle-free vision for driving in the clinic in Dubbo. So we need all the measurements to plan for that operation. And there might be situations where, you know, we're trying to give the patient a degree of reading vision as well. So perhaps the patient's no longer driving and they're elderly, and so all of those things need to be discussed with the patient, as well as the consent, the risks and benefits of surgery, because even though cataract's a very common operation, you know, there's still a 1 in 7,000 chance of a significant infection, and that needs to be discussed to make sure the patient's happy to proceed. Let's go ahead again, guys. Just conscious I've probably got about another 3 minutes, I think. So this is a video of a cataract operation. If we can run it at double speed, I'll just quickly talk to that for anyone who's not seen it before. This patient, so this is kind of the end of the operation, but here's the start now. Maybe I'll just talk you through a bit. So we make small incisions, two 1 millimeter incisions in the eye, and while we're operating, we put balanced salt solution over the eye so that it doesn't dry out, because when the eye dries out, we can't see what we're doing. A viscoelastic to inflate the eye and keep everything stable. Then there's a main incision. It's usually about 2.4 millimeters, and that's the main working incision. So we have to open the lens to actually get to the cataract. So you peel open the outer layer of the lens, which is a bit like the skin of a grape, and you can kind of tear it in a circular fashion, which allows you to access the hard cloudy cataract. You then hydrate that lens to make sure that it's mobile, so that it can be manipulated and moved, and then we use an ultrasound to start to divide that cataract into small pieces so that it can be removed from the eye. So there's different techniques to take it out, but this guy's doing a chopping technique. So that instrument in the left hand is a chopper that can do a lot of damage. Actually, not many people use it, but it can be used to break up the cataract and reduce the ultrasound power. Then the cataract's out now. You just got to take out the sort of outer layer, or the second most outer layer, to allow a clear shell to be left to hold the new lens. So we've talked about measuring the lens for the cataract surgery, and so once you've taken out that cortical material and cleaned the shell, you can look to put the new lens in, which he'll do that now, and then I reckon we'll move on. So he's got to open up the capsular bag with that elastic material, and then he's introducing the lens through the loader. So this is a acrylic single piece lens with a central optic and two little haptic legs that are going to stabilize it. There's also tiny little dots on this lens, so it's a toric lens, which is going to help reduce post-operative astigmatism and minimize the need for glasses. And then he's going to position it where he wants it, take all the elastic out, and seal up the eye, and that's the end of the operation. So that's good, Ali. We can probably go on from there. That's a nice operation. Patient gets an eye shield. They get eye drops, antibiotics, and anti-inflammatories. And the big things we need to remember: week 1 is infection, so any problems, you've got to call the ophthalmologist. Week 2 is back to driving and work. Week 4, patient can get their glasses updated if they need them. Talk about the second eye if required. And post-operative issues: inflammation, swelling, changes to the patient's glasses, minor irritation and glare would be the things that I got to talk about during that period to the patient. Next one. I think we're up almost at the end. So we're trying to empower our GPs and optometrists to have good relationships with our ophthalmology clinic people. We want timely and efficient access to care for the right patients, minimise delays by giving us the right information, and minimise the rejections. Not that we reject many, but we probably should be sending more patients back, so that we're trying to keep our spots for our most important needy patients. And kind of push the surgical patients through the clinic who we can really help, and the higher acuity patients who are going to come to harm if they're not seen, and manage our non-surgical patients and the ones that aren't ready for care in the community safely. And it's really a two-way process of communication and collaborating together, and for everyone to know who to call and when they need to call. And I think that's pretty much it. Yeah, you can get the criteria for the statewide referral on the New South Wales Health website, and there's a referrals page, and also the New South Wales Health Pathways pages. So all of these things we can provide at a later date for people to start to improve the quality of their referrals and utilise our clinics as best we can. I think that's pretty much it. Yep.
We'll go to our questions, Jeremy. So there's two different questions.
Yep.
The first one is from one of our local paediatricians,
Yep.
which I think that you might need to talk to them at a different point regarding this specific patient.
Yeah.
But he's asking, would you see a 9-week-old baby who is not able to fix and follow? Pupils are equal and reacting normal, and there's a normal red reflex, no notes of nystagmus, and developmentally normal.
I would say we probably will see that patient. I mean, it sounds like everything's normal there, but I think probably happy to see any child who you're concerned about. That's a pretty quick review for us to have a look at and confirm that everything's okay. So I think that's a hard one for a GP to be 100% confident about. And I think a child's visual development can be there's a quite a long a big range of what would be considered normal in terms of fixing and following, but for us to have a quick look and check that the pupils are well, basically that they don't have a cataract and that the optic nerve and macula look normal would be a pretty quick thing. So we would see that child. Yep.
Wonderful. And the second question is, could you please explain what it means when you've stated the first and the second eye?
Yeah, sorry. So obviously most patients have cataracts in both eyes, and or it can be asymmetric, but the worst ones, quite often the worst eye is done first, and then the better eye would be done second. So whether that happens in the same episode of care or whether it might be a few years later, the first eye that has the eye that has the first surgery is the first one, and the next one's the second eye. So it just relates to the cataract surgery and which eye goes first.
Wonderful. So they're the only two questions. We will add that after the webinar, we will send out a package to participants that have the referral forms for both Dubbo Public Eye Clinic and also the Outback Eye Service. So they're almost exactly the same. They're just pertaining to the location because, as Dr. Curtin has said, the criteria is the same across the state. So we'll try to implement those across wherever your patients are located. So thank you very much.
Thank you, Jess. Jeremy, thank you very much for the presentation and your time tonight. Ted, you're online, I can see.
Yep. Hi, how's it going?
You're good. Okay. Everyone, Dr. Ted Stoglos is here, and his session is diagnosis of colorectal cancer and the SRC implementation. Ted, you just let me know when you'd like the slides moved on. I'll mute myself. Thank you.
All right. Hi, everyone. So today, we'll be talking about the diagnosis of colorectal cancer because it comes up an awful lot, and it's one of the main referral reasons for colonoscopy. And it's actually changed quite a lot in the last 2 or 3 years. So it's actually the SRC coming in at this time is actually a really good opportunity for us to maybe change our practice a little bit because the evidence is really changed the way things are going. So I think you're all probably fairly familiar with the National Bowel Cancer Screening Program. So I think we're quite lucky in this country that you know, Australians between the ages of 50 and 74 are sent a fecal occult blood test every 2 years, which reduces, you know, those which are positive. So about, you know, less than 5%, go on to be referral criteria, strong referral criteria for colonoscopy, which reduces the chances of people dying from colorectal cancer by about 25%. And GPs have a really important role to play in this, in ensuring that, you know, it gets done and that referrals occur, and the follow-up afterwards in many cases. So yeah, this is the critically important thing. Next slide, please. Okay. So there is, I only found out about this recently, there is apparently alternative access to bowel cancer screening kits for healthcare professionals. So not all of our patients, for one reason or another, will actually receive a kit from the government, and it can actually, the handing out and performance of fecal blood tests can be facilitated by general practice. And there are avenues by which you can register for access, get training, order the tests online, hand out kits, and access extra resources. So next slide, please. Okay, so there are signs and symptoms of bowel cancer, which you're all familiar with. The positive predictive value of these things is pretty low, about 2.5%. So, you know, some patients may have fatigue. Some of those patients with fatigue may have iron deficiency anemia. Some of those patients with iron deficiency anemia may have bowel cancer, right? And the same goes for all of the symptoms that we're talking about. They're not particularly suggestive. The things that are really strong risk factors for bowel cancer are age, family history, iron deficiency anemia, and a positive fecal occult blood test, which we'll talk about. So next slide. Okay, so this is the sort of practice changing study that I'd like to focus this talk on. So when I was training in gastroenterology, that's not that long ago, right? We were all told that, you know, fecal occult blood tests are a screening tool. They're a population screening tool for asymptomatic individuals to determine who's at high risk of having colorectal cancer, right? And that was the accepted logic. And in fact, the Gastrointestinal Society of Australia only 5 years ago put out a position statement saying that, you know, this is the use of this test and that we're not to use it in symptomatic people, right? And so this has been accepted wisdom and common practice, you know, for quite a long time. So look, this study 2 years ago from the UK has really changed things. So not only has it informed our statewide referral criteria, it's completely changed the pathways for colonoscopy referral in the UK. So this has completely changed the practice in the United Kingdom. So what this study is it's a study of 50 hospitals in the UK where patients were referred from primary care with suspected colorectal cancer on an urgent wait list, and they underwent a fecal occult blood test followed by a colonoscopy. And the primary outcome was how sensitive is a positive fecal occult blood test in a patient with rectal bleeding referred for suspicion of colorectal cancer. Okay, next slide. So this is, you know, close to 10,000 patients, right? So this thing was massive. And 30% of those patients were referred with rectal bleeding, either alone or in a combination of other symptoms. And look, what they found is that in patients with a positive fecal occult blood test in rectal bleeding, there were 844 patients with a positive fecal occult blood test in rectal bleeding, and 142 of those people had bowel cancer. And for a negative test, so there were 2,000 negative tests, and they only missed 5 cancers. So as it turns out, the performance of a fecal occult blood test in a patient with rectal bleeding is actually really good. So next slide. So the other thing to say is that, you know, the accepted wisdom used to be for a really long time, right? That if a patient had rectal bleeding, of course, they'd have a positive fecal occult blood test, right? You'd think. So if the patient is reporting rectal bleeding to you, why am I going to test the blood? They've got microscopic blood in their poo. But it turns out the fecal occult blood test is only positive 44% of the time for patients with rectal bleeding. So it's not particularly predictive at all. So what they found in the end, that with a cutoff of 10 unigrams per gram of blood in the feces, right, which is what we use in Australia, this test, so a fecal occult blood test in rectal bleeding was 96% sensitive, so really sensitive. So this is, as I said, this has changed the practice in the UK, and this has really informed our criteria that we've done. So next slide. Okay, so a Cat 1 referral for concern of colorectal cancer is a positive fecal occult blood test. The National Bowel Cancer Screening Program is a Category 1 referral for a gastroenterology clinic, and it is almost always a Category 1 referral subsequent to that for colonoscopy. Okay. Oh, sorry, previous slide, sorry. And it also included in there is more than 5% or 10% unexpected weight loss over 1 to 6 months or abnormal imaging. All right, thank you. Next slide. Okay, so as we said, family history is also incredibly important and is included in the statewide referral criteria. So guidelines are published by the Cancer Council of Australia. So we generally try and work out if people are at near average risk, moderately increased risk, or potentially high risk. So the main thing you've got to look at here is with a family history of colorectal cancer, what's really significant is the age at which the relative was diagnosed. So if it's at the age of 55 or older, that's not particularly suggestive of a genetic syndrome because it's incredibly common to have colorectal cancer over the age of 55. So the age at which the family member was diagnosed is incredibly important and should be included in the referral and is part of the criteria. So next slide, please. Okay. So the criteria also includes surveillance for colonic adenoma. So surveillance for colonic adenoma is going to have a lot to do with how many polyps you found, whether they were a centimeter or larger, and whether they had high-grade dysplasia or villus features. So to accurately triage a patient for a clinic appointment for polyp surveillance, really, we need to know how many there were and what the histology showed. So look, if you have access or are able to get access to previous colonoscopy or histology reports when referring patients for polyp surveillance, that changes things an awful lot. Okay, next slide. Thanks. Okay. Some practice points. So for low-risk colonic polyps, a colonoscopy interval of 5 years can be considered for patients with metabolic syndrome, which is a decent proportion of our patients. So I'd say there aren't many patients who would wait 10 years for a colonoscopy, even with diminutive 1 or 2 even small polyps. If a significant family history of cancer is present, then they probably need one sooner. And the patient can actually think about returning to the National Bowel Cancer Screening after 4 years with a low risk finding at colonoscopy. So I suppose the thing to know is that with a low risk finding at colonoscopy, it's highly unlikely that there'll be another cancer detected in the next couple of years. And in fact, the statewide criteria include that a patient who's had a high quality colonoscopy, so that means the preparation was good and they reached the end. So if the preparation was good and they reached the end, they had a high quality colonoscopy, they probably don't need another one in 2 years. Okay, and the last thing to say, last slide. The last thing to say is that over the age of 80, we'd appreciate not receiving referrals for surveillance colonoscopy, as it's not generally recommended. And people between the ages of 75 and 80 with a significant comorbidity also probably shouldn't be having surveillance colonoscopy. Okay, thank you. Next slide. All right. So the next question that I think we should all be thinking about is when we're doing fecal occult blood tests to detect colorectal cancer, you know, and we're repeating it all the time, does repeating the test actually increase our detection over time? And there's a pretty large study from Italy of several thousand patients showing that that is actually the case. So by the time, you know, people have reached their 60th birthday, right, and they've been doing the bowel cancer screening for 10 years, we've actually got an adenoma detection rate of 6% for advanced adenomas. So doing it 5 times in a row is almost as good as doing a colonoscopy on everybody, believe it or not. So repeating the test is definitely worth doing. Okay, thanks. Next slide. Okay, so this is included in the referral criteria. So people with a family history of colorectal cancer, like we've talked about, can definitely be referred for screening, and that's generally seen as a category 3. In Dubbo, you're very, very unlikely to be waiting a year to be seen in the gastroenterology clinic. Almost all of our patients are seen between 3 or 4 months. And I suppose the other thing that they talk about is, so a personal history of polyps in a patient over the age of 75, you should be thinking about what is their Charleston comorbidity index score. So next slide. Yeah, so what we're saying is they can have one of the conditions listed on the left, right, and not any of the conditions listed on the right. So a lot of this is kind of common sense stuff. So if you're over the age of 75 and you've got a few medical problems, it's probably a bad idea to do surveillance colonoscopy. Okay, thanks. Next slide. Thanks. All right, so we're going to talk briefly about other conditions, okay, listed in the criteria. So iron deficiency anemia. So, you know, the performance of a fecal cord blood test in iron deficiency anemia is probably not quite as good as rectal bleeding, but it's still definitely worth doing. I would strongly encourage you all to do fecal cord blood tests on your patients with iron deficiency. So as you can see there, a positive fecal cord blood test over the age of 40 is an indication to be seen within a month. And the other criteria are quite similar to rectal bleeding. Okay, next slide. Okay, hepatocellular cancer. So look, if you've got a patient with cirrhosis with a new lesion in the liver, you know, refer them to us and they'll be seen quickly. I suppose the only exclusion is a simple cyst. So if they've had radiology that shows a simple cyst, you know, we can still look at it or discuss it, but it's probably not urgent. Okay, thanks. Next slide. So inflammatory bowel disease. So you're all probably familiar with the criteria for a severe colitis. So patients with a severe colitis need to be referred to the emergency department. So if they're having more than 6 bloody stools a day and they're anemic and tachycardic and febrile, they need to go to ED. But I think the other thing to think about is patients with known IBD who are getting worse. So we've got a high calpro, new symptoms, new anemia, low albumin, abnormal imaging, a pain or a fistula is suspected, then they can be seen definitely within a month. Yeah. So next slide. So liver dysfunction. Okay. So abnormal liver tests. I suppose the main thing we think about with abnormal liver tests is, you know, how long has this been going on for? But even on a one-off test where things are looking really bad, so if the bilirubin's greater than 34 and the INR is greater than 1.7 on a patient who's not warfarinized, they'd definitely be seen within a month. For a lot of other patients, it's probably worth repeating the test a few times just to see what the trend is. A lot of, as you're all aware, a lot of liver tests will become fluctuantly abnormal and then correct themselves over time. The other thing to think about is that a new abnormal liver function in a pregnant lady is an urgent referral, and we see a lot of those patients urgently. Okay, next slide. All right, cirrhosis. So a patient who's decompensated, so is jaundice, ascites, gastrointestinal bleeding, confusion or encephalopathy, can be seen in the outpatient clinic within 30 days. It is also probably appropriate for them to be referred to the ED, actually. So if a patient becomes jaundiced or has new ascites, an ED referral is also appropriate, but you could refer them to the gastroenterology clinic. Okay, next slide. Upper GI dysfunction. Okay, so any patient who's got new swallowing trouble, so any patient who out of the blue can't swallow solids, you know, progressive, maybe they can't swallow solids, then over time they can't swallow liquids, maybe they're losing weight, they definitely need to be referred to the outpatient gastroenterology clinic as a matter of urgency for diagnosis and treatment. Patients who've had long-standing swallowing problems, it's usually not quite as big a deal, but we'll definitely see them. Heartburn with red flags. So the red flags for heartburn, I know you're all familiar with this. So it's bleeding, weight loss, dysphagia, iron deficiency, family history of cancer. And it's also got in there abnormal imaging of the upper gastrointestinal tract. Okay. Yep, and next slide. And those are my references. So I thought I'd do a quick one for you guys. Do you have any questions about any of that?
There's no questions in the Q&A box, Ted.
Okay, excellent.
Yeah, so I think everybody's just trying to take that in. And as a reminder, the PHN education team, so Ali will send them out. If you'd like any more information, so more sessions or on either ophthalmology or gastroenterology that's been discussed tonight, please take the opportunity to fill in this survey. That would be very helpful, wouldn't it, Ali?
Yes, thank you. Thank you, Ted, for the talk. Thank you, Jeremy.
Thanks, guys.
Jess, thank you for your help tonight. I've just put the evaluation up too, if everyone wouldn't mind logging on and evaluating. That would be great. Thank you very much. We'll send the slides out and certificates. Thanks again, everyone.